Thanks. Should be on the test.
So we have a 60-year-old male with a recent history of cataract surgery in the right eye 1 week ago. He had reported the vision was foggy after surgery the following morning with a dark spot slightly above his central vision. This had remained stable since onset. There was no change in vision in the left eye, no focal nerve deficit, and then recent kind of cardiac labs were normal. Clinical history non-contributory, surgical history non-contributory, and had only been on Nexium and ibuprofen. The vision in the right eye at distance uncorrected 20/80, and then pinhole 20/32 + 2, and the left pinhole to 20/25, and the pressure was normal. So we have a photo for Keith to describe.
Right, color fundus photo, right eye.
False color.
Oh, okay.
This one,
Yeah, it's like got that
Yeah.
greenish.
Remember that.
yeah, multicolor.
Media, what I can see if here is clear. Nerve looks a little, I mean, with that false color, the nerve, it's difficult to kind
You
of,
can point to the nerve.
alright.
On that screen there.
With the false color, the nerve, it's kind of difficult to hit a true color of this, because it really appears dark in this, but, you know, be about the vessels or anything. Vessels appear normal. With the macula, I almost want to say there's like a little teeny spot here, but that could just be regular reflex, but then this, like the color of this looks a little bit different over here. And kind of this
great.
region looks a little lighter in color than it does up here. I don't know if that's significant or not.
And I think, do we get a real color?
It almost looks green.
Um,
Green is the anterior on this.
Yeah, green is empty.
I'll show you the left eye to also compare, because there are some kind of color
Yeah,
Yeah,
nuances.
I don't, that difference between the top and bottom, I don't quite see that so much here. Like, you can kind of see like the stippling underneath, that's normal. On both sides, I think that was a little harder to see in the other eye.
you know, the Claris is an LED camera. It's interesting. I don't know if you guys know that, but the Heidelberg and the Optos are laser cameras, and that's why they give you that green. They can't quite get the wavelengths. And the Claris actually sweeps LEDs, which is pretty cool, I thought.
Okay, so let's see.
All right. So we're not quite, I mean, it doesn't look like we're quite at the entirety of the foveal contour, but it does look like the layers are just like a little thicker. Like all the layers just seem a little thicker than I would normally expect. Maybe it's just kind of that the image is smushed.
Yeah, the inner retinal layers are a little bit more edematous, a little bit of the outer layers as well. And then we have a different cut through the OCT.
And then this is vertical where this arrow being over here, I think. Yeah, I mean, the contour looks a little odd. It's hard to say if that's just because the picture is like,
Yeah, I think it's just squished.
Yeah.
I think it's just
Well, you got
squished.
you, look at the
Yeah,
double layers.
yeah.
It's the
Am
color.
I able to
Yeah.
point on this?
Yes, I think so. Maybe.
so. Ooh.
Oh, that's probably too much.
I don't think they can see that though. I
Yeah,
think
the
the other
other layer
layers.
is basically like from here to here, which I think corresponds with this.
Yes, it does.
The color is just, it's different, it's lighter in color. Yeah,
So
Yeah, that's-
reflectivity, so you're getting increased reflectivity from those layers.
That's exactly what I was pointing out with this big thing. Okay, so that's exactly it, hyperreflectivity of the inner retinal layers there. Okay, so
Which layers are those?
the inner retinal layers?
No, go back. It helps a bit. So which ones are off in that? Is it the
I
outer,
don't know
middle,
if I did
or inner?
Or the more of the middle, more of the
More in the
middle.
middle, more in the middle.
Okay, so we have the FA, and I can show you a couple of different photos for the sequence. This is at 15, just about 15 seconds.
okay,
And then I'll show the sequence, and that's the left eye, so.
Oh, yeah. Strike me as too different. I don't know. I mean, I guess like this area is a little more hyperfluorescent than the surrounding, but it's hard to tell if that's just because of the like a eyelid here.
No.
Yeah, I think some of it's artifact. It's very early, so what phase is this?
Like the arterial phase.
That vessel going into the macula, what vessel is that?
This,
That one, no, below it.
Just below.
The one where the pathology is.
the cilioretinal. I would have thought this would be.
Now look where that one starts, look where they all start. You gotta get the. So the
Okay,
origin,
yeah, so these are starting centrally. This is not.
right,
This is starting right here.
so that's a cilioretinal, right?
Mhm.
And so you can tell it's an artery because of the angiogram.
Hmm.
The rest of the stuff, or very early for, let's see what happens on the next frame. Does that stuff go away?
So it just is a little bit more delayed.
Go a little more? The
No,
other thing on him, he's got
eventually.
floaters. So a lot of that dark stuff, this patient had, the floaters are crazy on the float. So a lot of that dark stuff is actually floaters in the eye. He had a lot of floaters. But, so anyway, so if those dark spots are moving like that, it's actually floaters. You know, 8% of surgeries, vitrectomies now are mostly for floaters in the US.
Really?
So recent, they're straight vitrectomies, which are, it's interesting. I think it's
Patients.
appropriate, but it's,
We get patients coming in all the time asking for it.
Yeah.
I don't think we really do that.
yeah, it's actually, it's not in a pseudo, like, if they're symptomatic, but anyway, that's another thing.
We had a guy who crashed his car into a ditch and he told us, he's like, I gotta get this floater taken out. It almost killed me.
Oh, yeah.
Does insurance covers it?
Yeah, there's a code, there's vitreous, like, it's really meant for vitreous hemorrhage,
Yeah.
but it's
Yeah.
vitreous opacities and you do vitrectomy, it's covered. Yeah, but it's amazing, it's almost 10% of vitrectomies in the
You ever
country.
hear of herb cancer?
Yeah.
He, his wife had it done.
Floaters, yeah, I operated on, Ryan, the Retina techs, Ryan. I took floaters out of his
you
cousin's
really?
eye, not him, no, his cousin. I was thinking he'd be turning over in his grave. She was that, anyway, so go ahead, sorry, she was thrilled,
It's a left eye.
It's like we're in a bar.
yeah.
Module.
Fine.
Okay, so what is on your differential?
But what's your findings? Go back to the images. So the fluorescein, would you call anything on that fluorescein abnormal?
But like I said, kind of, I guess it's hard to tell just because of the artifact. Maybe this around the cilioretinal artery is like slightly darker than.
Well, it doesn't correlate with cilia.
Yeah, it doesn't really show.
But it sure, I mean.
No, I think
it
it-
looks like a kidney bean, right?
Yeah,
Yeah, but yes, I think that's just the floater.
yeah.
I really do. And then on the, so the main findings, the OCT and the
Maybe
color.
some like subtle delayed filling in that vessel.
Yeah.
That's what I had
It's
thought.
not as bright as the others, but that also could just be.
I think it's just filling.
Yeah.
It should fill a little before the arteries, so maybe, cilioretinal should fill like whatever, half second before the central, but that's, who knows? But then, so the main thing's the OCT
And
the
false color.
and the false color,
Yeah.
So the that OCT scan is
It's
not.
like
normal.
paracentral acute middle maculopathy.
Yeah.
Yeah, so there's that, so there's a PAM lesion, and then the color, and then you can see it on the IR. So on the IR on the left, you see the dark area,
Yeah.
right? So where do you think that dark area is? So go back to the color,
So
false
right-
color.
Right here, whoops,
You want,
I was saying like right here is this edge.
Yes, yeah.
Right here is this edge, because this is the arrow and the
Yeah,
arrow points to
yeah.
the
Right.
right.
But then the thing is it a little abnormal beyond that? I think it is, maybe. Like if you go that edge, the edge you're looking at is where it's strikingly different, but if you go to the left of that,
Oh, like here, it's just kind of like indistinct.
Yeah.
The border.
because the layers thin out, and then look at the false color. Which is all we have.
It looked like there
Yeah,
was
this
like
was kind
either
of,
like pallor or like a fluffiness.
yeah, it's like funny looking here, it's greener.
It's hard to tell.
Where's the artery?
See like,
That's the artery there, the bottom one.
This,
And then what was the history? When did this start?
it happened the day after, the day after cataract surgery.
Right after, yeah,
Yeah.
right after. So this was right after. So sudden vision loss, right?
And they
That's why I
noticed
thought
a
it's.
superior
Because
difference.
sudden vision loss after cataract surgery with the thing is kind of important. All right, so go ahead. So
So, yeah, mainly the hyperreflectivity and then the dentist layers.
So Pam is a finding. So what are you gonna attribute the Pam to? You can't just say Pam. Pam, like AMN is a diagnosis, but Pam is associated with the central vein occlusion. What's this? One of the residents published with me, they saw it in birdshot. You see it in artery occlusions, you see it in mostly vein occlusions, artery occlusions, some inflammatory diseases. So what do you think caused the Pam in this
I
patient?
mean, it seems in, like you had pointed out, it seems in the kind of region of the cilioretinal artery. It might be sometimes associated, but I mean, if it was a little delayed in filling, it still looked like it was filling.
Well, the thing about occlusions is they typically reperfuse. So it's rare, it's almost, I'm trying to think if I've ever seen an artery occlusion that hadn't reperfused. Now I think of it, it'd be interesting to look at, like how many nice paper, artery occlusions they present. I think they're almost always reperfused. So when they branch arteries, so when they come in, you start to see the evidence of overall branch artery occlusion, but usually the occlusion itself is gone. But anyway, so I think this probably wasn't, so go ahead.
Dr. Cohen, was
Yeah.
I knew that we didn't have a true color fundus.
Yeah.
Was it as striking? on
No,
the
it's
color
kind of
fundus?
gray, it's sort of this grayish. So it
Because I'm
wasn't
not
white.
sure if I saw this guy in ED, I don't know that I would pick up on that without no CT.
Yeah, you would, it'd be hard to, and this patient was actually referred by a retina specialist because of the
Oh, all right.
Pam lesion, so this was a hard case, a pretty decent retina guy, so it was a weird case, so that's why I thought we should do it, so I think it was Pam, but I think it was an occlusion, I think Pam's usually an occlusion, I think it's usually either an artery or a vein occlusion.
Well, what's interesting about it though, is with the artery occlusions, a lot of time you'll have retinal nerve fiber layer edema, right?
But not, yeah, but
Middle, it's like. the
sometimes
watershed
it's
area.
middle, we had one earlier this year, the last artery occlusion I brought to conference was actually more middle.
This,
So I think,
yeah, this is probably partial because
yeah,
it's the watershed area between the choroidal and the retinal circuit. Like the pan-
Right.
gives you the pan.
yeah, why it's sometimes middle and why it's sometimes superficial, I'm not sure what that is. You know. Oh, say it's-
Okay. So, I just went into ischemic, mechanical, and then inflammatory causes. For ischemic, we have our artery or vein occlusions. Mechanical, that wasn't really prevalent on the OCT, but just VMA, VMT in case of any retinal edema, and then any pseudophakic CME, also not a super classic presentation in terms of what we had. So ours was a cilioretinal artery occlusion. In terms of anatomy, so the cilioretinal artery branches off the short posterior ciliary artery, typically less commonly from the choroidal vessel. So in the FA, it may have felt a little bit before the kind of arterial phase. It would be in maybe the choroidal or pre-arterial phase. And you can see in the picture here, you have the ophthalmic artery, and I guess I only have this kind of
Your point.
big pointer. So ophthalmic artery, it has the central retinal artery branching up here. Thanks.
Then other people can see it.
Oh, perfect. Okay, so let me get back. This is just a different view for some people may prefer that one. So the ophthalmic artery branches into the central retinal artery and feeds most of the retina. And then we also have the posterior ciliary arteries, and this shows the branch off is the short posterior ciliary artery right here. And then this artery is not present in all individuals. I had seen a paper showing a very wide range in terms of prevalence. It said 6 to 50% of individuals, but I think most papers said around 10 to 20% was more likely, providing that extra supply to the macula. CLRAOs make up about 5 to 7% of all retinal artery occlusions, so certainly not the most common. And then it can occur in isolation in association with the CRBO. And that's thought to be from the high pressure, the high intraluminal pressure, backing up into the capillary bed and then preventing blood flow from the cilioretinal artery. And then also in association with an AION.
If you had really high eye pressure during surgery, could you get some transient ischemia? Say they like just cranked up the pressure.
Well, that's what, are you gonna talk about?
Yeah,
Okay,
so different-
just gonna talk about vision, because I thought the interesting thing about this was the proximity to cataract surgery.
Yeah, the timing.
So the next picture is just a different schematic to show this in a different plane. So ophthalmic artery, and then we have the central retinal artery. And then here it's showing the branch in the lacrimal artery, but also the posterior ciliary artery, and then the short branch right here.
So those are, so you got your short posterior ciliaries and then your long posterior.
Yeah, they
ciliaries,
showed a
so-
little bit separately, but the long was here, and then the short was right here,
Okay,
branching off the posterior ciliary artery medial, and then there's the lateral one over here.
Right.
Okay, so vascular events following cataract surgery can certainly happen. It was listed as a rare complication in all of the kind of reports I had seen. And I had seen varied ranges of prevalence for this as well. Some, I think the Bascom report mentioned like 1 out of 2,000 cataract surgeries could have an AIO1, and then I'd seen as high as like 4%. So it was quite varied based on mainly case series, and artery occlusions and vein occlusions as well. They had listed mainly in these case series the potential mechanisms that could cause this, since it's hard to understand the actual pathogenesis in a case series. So I go into each one a little bit further in the next slide. Okay, so ocular risk factors. If your surgical patient has a history in the fellow eye of any occlusive event, like an NAON, artery occlusion or vein occlusion, that would increase the risk in the other eye. If they have, if they're vasculopath and they have diabetes, hypertension, hyperlipidemia, and so forth, that would also increase the risk. And then anesthesia type, they had mentioned retrobulbar and then peribulbar would have the higher risk compared to topical anesthetic, but this patient actually had just had topical for his cataract surgery. But for retrobulbar, it's you could actually injure the nerve itself. The volume from the anesthesia could also compress on the nerve or the vessels. And then could also cause vasoconstriction and then vasospasm as well. In terms of perfusion, they had mentioned, especially in a vasculopath patient, if their blood pressure is well controlled during surgery, it may be too low for their ocular perfusion if they are typically a hypertensive patient. And then especially for the IOP elevations, like Alex had mentioned, intra-op and then also in the post-op period were important to note.
I like the perfusion better though, because that's the anesthetist's fault.
Yeah, correct.
And the thing with these is it's so rare, because we spike the IOP constantly. I mean, I tell you during retina surgery,
Oh, yeah.
I push it up to 60. Like if anything looks funny, I'm just like, put it to 60, for a couple, not for 10 minutes, but for like 3 or 4 minutes, just because everything fills up and you hardly ever see this. So I would expect it to be, and I've done thousands of retrobulbars, and it's very rare. So it's a weird mechanism. But it's definitely true. It happens. And then the other thing is if they get it in one eye, aren't they like super high risk in the other eye?
Yeah.
Okay.
Yeah, that's what, remember I said that.
Yeah, you said that.
The other day, or the other month.
And then inflammatory causes. So they had specifically mentioned like if there's a PCR, the posterior capsular rupture that could also predispose, so leading into direct surgical manipulation, that PCR, or vessel injury, perhaps if you're in a posterior segment
What about
surgery.
drops and injections with VAC? I mean, I don't do cataract surgery.
Oh, the medications they use?
Yeah, any
I don't
epi,
think this patient got.
Hmm.
any epi?
Oh, epi, yeah, again, I use epi on every case.
Do you-
But
Like the vasoconstrictive effect.
yeah, they put it in the bottle, every vitrectomy, I think. It's epi. Go ahead, sorry.
Oh, that was all I was gonna say about that. So these are the kind of main the main mechanisms that they had proposed, but it's hard to know in the majority of the literature was just case series, so. Just things to think about, especially if you have a patient who's high risk, they have it previously, their vascular path. And to think about this when it happens.
I know the fellow eye, I think it was like 20/80 pinhole, 20